It is a great honor today to be interviewing everyone's legend in CBCT cone beam. No, seriously, Dale, Dale Miles is a board certified oral and maxillofacial radiologist, which is the American Dental Association's ninth specialty now. The only acronym I can think of for the nine specialties is POPE Poodoo. POPE, POODO. Periodontists, prosthodontists, oral surgeons. But Dale, I kind of think that they became a specialty because radiographs went from two-dimensional to three-dimensional. Is that a fair assessment?
Yeah, that's kind of the nutshell version. What was happening is that in dental schools, and I'm a recovering academic, right? So in dental school,
and to our viewers, Dale is absolutely. How many board certified oral and maxillofacial radiologists on there?
Approximately 212, 215, somewhere in there.
Yeah, it's a brand new profession. Compare that to orthodontists, where there's 10,500.
Absolutely.
And this is brand new. And Dale, when I'm on Dental Town, when anybody's ever talking about CBCT, they always say, well, Dale Miles said this, or Dale Miles said that. I mean, you are absolutely known to the 180,000 townies on Dental Town as the authoritative figure in CBCT, digital imaging, basically all things radiograph, but more importantly and more specifically, as they've gone digital. Would that be a fair assessment?
Yeah, I actually did something early on. I had a good friend who said you need to brand yourself in your area of radiology, and I adopted it early. We did a lot of research in digital solid state detectors and other modalities. And so I started talking about it in 1991, okay, and I posted a website with all those articles on it about digital to help docs, make those decisions that they needed to do. So
and your website is very robust. LearnDigital.net.
Yep.
And that's got pretty much anything that a dentist or a staff would need to know about digital radiography and CBCT.
Yeah, it's kind of transitioned. Cone beam is just the higher end of digital imaging, so it's kind of transition. More articles are up there now on cone beam imaging than digital. Digital tends to be not in the background because there's still huge numbers of people that have to adopt, as you know. But I've gravitated more towards the cone beam side.
Okay, and I like to just call it 3D radio.
Sure.
2D to 3D. These podcasts are listened to people from every country on earth. First of all, explain exactly what CBCT means and why they went with that name.
Yeah, thanks for asking it that way, why they went with that name, because CBCT means cone beam computed tomography, but it really isn't computed tomography. What does computed tomography actually mean? That would be like conventional CT. If you were to go to a hospital, be put on a gantry and then pushed in a millimeter or a centimeter at a time into an imaging device, a great big imaging device. Basically, that would be conventional CT, CAT scan. Okay. Dental, quote, cone beam CT bears no resemblance. It's like a panoramic on steroids, really. It's one pass. Sometimes it's not even a full 360 degrees, and you get comparable data to look at in 2D and 3D, but with a minimal amount of dose, and that's huge for dentistry. So cone beam CT is a misnomer, really.
You say it's a minimal amount of dose?
Minimal. And let me give you some numbers. Don't worry about the units. If depending on the field of view, which is the size of the area captured, okay, the part of the head captured, it'll range anywhere from as low as maybe 25 microsieverts up to possibly 125, 130 microsieverts, depending on the machine, the size of the field of view, whatever. Medical CT, if I were to do a conventional, CAT scan of your head, Howard, it would be 2,100 microsieverts. So that's a whole order of magnitude less dose. Now, the thing is, we don't get gray and white matter, and that's a good thing. You and I can't look at a data volume and look at, the brain matter. That's for a medical radiologist. So we don't get that kind of data. We get bone, air spaces, some soft tissue, and it's really, really dentally applicable.
So Dale, let's get cut right to the chase.
Sure.
Now, digital radiography, my goal, going back in the day, this is right now, we're at 2014, but back in the day, between about 97 and the year 2000, the whole world thought of Y2K. Our younger viewers who are in dental school, who are probably in grammar school, Y2K, basically, everybody had to upgrade all their systems. So my goal was, I'm just going to go paperless. So we went paperless and we went to digital radiography. 2014, 14 years later, what percent of the dental office do you think in the United States specifically have gone from film to digital x-ray for 2D x-ray?
Okay, for 2D, grayscale imaging, I think we're still somewhere in the neighborhood of only about 55% of our colleagues adopting. And I'll say digital manufacturers will include phosphor plate as a digital technology. It's an indirect digital capture where you and I know you capture it on a plate, stick it in a scanner, so it's a little bit more time consuming. But if you mix those two together, about 55% adoption. So we got a long way to go. And the stuff was introduced in 1988 at the Chicago Midwinter.
Okay, so Dale, so let's say that half my viewers are using film. Let's say that.
Sure.
What would you say to them? What would be the reason to go digital over film?
Oh man, you don't have enough time in the program. There's so many attributes. There's so many good, solid reasons for going. I'll give you a term that you use as a professional and I use, but as a radiologist I use it a little differently, and that's ROI. ROI for a dentist means return on investment. For the manufacturer selling the product, return on investment. For me, it means that, but it also means region of interest, okay, as a radiologist. But, you cannot believe the actual, let's say, how quickly the return on the investment happens. The dental X-ray image, no matter what flavor it is, it has the highest margin of anything you do in your dental practice. I don't know if you know that.
Repeat that again.
The dental image, the dental X-ray, we'll call it for sake of just calling it X-ray, has the highest margin of any procedure you do in your practice. Give you an example. 15 years ago, I was in the Midwest talking about a single PA in film, start to finish, tech time, cost of chemicals, disposal, and the cost of the film, about $1.11. The actual charge for that in the Midwest that many years ago was about $15. Okay, now a single PA might be as high as $31. So it goes from and even digital, it's about $1.25. So $1.25 to $31. Are you kidding me? Okay, now I'm a radiologist. I'm not telling my colleagues out there to take X-rays to make money, but we almost need imaging on every patient that walks in the office, recare patients, new patient exam, all the things that we see, growth and development issues, impacted teeth, you name it. We need imaging information. So when you think about it, and see, that's the thing docs don't do. They don't think about it. It's out of sight, out of mind. Get those images better, and they better be perfect. They don't do the actual procedure. Here's my suggestion to your followers, to the townies. Go in your practice, and some of them have done this. Go in your practice management software and query a report, and just ask your report to do nothing but the twos, the CDT codes that capture dental X-ray information, even if you don't do them, and generate a report for 6 months or a year and look at the bottom line, and you'll go, OMG, this is amazing. And digital helps you get there a lot faster. Plus, the image information is instant. You can educate your patient chairside a whole bunch better. There's no chemicals. It's a lot greener, okay, than basically film. So, I mean, like I said, I could probably go on for another, hour and a half giving you a lecture on why you should go digital. But stuff's on the site; they can read it there as well.
And my thing that I did it the most is that you're either dentist focused or you're patient focused. And
there you go.
Having a film an inch wide on a view box is not patient centered or mastery. Blowing that film up on a big monitor and then being able to print that out. Mm-hmm. And trace the nerve in a red pen and then draw a circle around the cavity that's usually interproximal and let them see that It's only this much more farther, and it's going to go from a $250 filling to a $2,500 root canal buildup and crown. And you know what? We need to do this now. And you haven't been in the office for 3 years. And Dale, if you leave this office with that flossing cavity, the next time, because you don't have insurance, so you don't have insurance to help you pay for $250, you're going to come back in pain. And now you're going to have to give me your credit card for almost $2,500. And and in a profession that has to diagnose 100 cavities to treat 38, I wish they would quit always talking about how to do a filling and start talking about the 2 out of 3 fillings. They don't even remove the decay.
Right.
And when dentists start talking about the difference, the pros and cons of amalgam versus composite or self-etching or total etch, I say, you know what? I don't care if you removed all the decay and packed it with IRM. Can we just get the patient to get the decay out? You know, they never talk about the cavities that were never filled. But Dale, on the street, and you know, I lecture a lot. A lot of dentists just say, Dale, the image on digital is not as good as film. What would you say to that dentist?
Go to my website and read the digital imaging chain article. Howard, here's the deal. The technology is always out ahead of the education, okay? So manufacturers are selling us products that look really sexy on the exhibit floor and in our office when they show on their laptop. But it's like digital imaging, when you adopt it, is like a stereo system, okay? If you got cheesy $19 speakers and a great Bose amplifier, you're still going to get crappy sound, correct?
Correct.
So what dentists don't think about is that it starts with the X-ray generator. You know, how many people, when you go around and lecture or we visit offices, how many people have an X-ray generator that's older than 15 years?
Oh yeah, or they bought the practice 15 years ago from a guy that was 70, and it's the same equipment.
Yeah, and it's 30 years old. So think of it this way: it's the image, it's the generator. It has to be a contemporary one. It has to be what we call a DC generator. Around 70 kV is probably ideal. Then it's the detector, the solid state detector, and we'll stick to solid state. You know, a sensor that goes in the mouth. The sensor, you know, basically there isn't a bad one in the marketplace. But what they do is you have to display it on what? A chairside monitor. And docs buy cheap. I hate to say it, but, you know, we're quite frugal and habit bound. You go to, you know, Best Buy, buy a $200 monitor. What goes in is what you get out. So the frame grabber could be wrong. The monitor could be cheesy. It'll show color real well. But when you go to show grayscale images where you only get 256 shades of gray, it's a whole different ball game. So you need to match your components like you do in a stereo system. And heaven forbid you want to print it out. You said something about printing it out. Well, here's the deal. I don't know if you've thought about this, Howard, but color printers make grayscale images out of blue, green, and red. Are you with me?
Yes.
So what you want to do is you want to hunt, you want to do your due diligence, find a printer that also does grayscale. You take out the color cartridge, put in a gray and a black, or you add a grayscale toner. And when you ask it to do black and white, it does a beautiful image. I'd also print, if people want to print, you know, to show whatever the patient, send it off for the endodontist, print it on a glossy paper, a photographic quality paper. The image is stunning when it's on that, when you've matched all these components up. A lot of it's the monitor, though, Howard, is, you know, if you're going to be making your decisions off it, you better have a good one that'll display grayscale like better, as good as color.
And that's interesting you just said that for me personally, because last week I just switched from a 3-year-old Dell computer.
Yep.
And all my friends, basically my boys, convinced me. They said, Dad, you got to go to Mac. And so I got the MacBook Pro, and the first image
Boom.
I pulled up, it's like, oh my God. And I still had my Dell.
Yeah.
Now, and I don't know what the monitor is, 3 years old, but I mean, the difference in just looking at a clinical picture, I mean, it just blew my mind.
Yeah.
I mean, the Apple computer.
And you're making clinical decisions on those images. So you don't want to shoot yourself in the foot off the bat. You want as much technology as you can afford that displays it so that you and the patient can see it. But not only that, when you're looking at X-ray information, you can actually detect the fine detail in it.
And I want to say something earlier about you said about return on investment. I always hear, accounting has only been giving us 3 statements for the last century. They give us a profit and loss statement, which is for a third-party tax collector. It's got artificial numbers, deferred taxes, depreciation. There's a balance sheet, your assets equal your liabilities minus your equity or whatever. And, that's if you're getting a loan or dividing assets in a divorce or something. But the main thing is the statement of cash flow. And dentists always look at these machines and say, I don't want any debt. I don't want any debt. And that's just an emotional knee-jerk reaction. Well, we don't look at the balance sheet number of the debt. We look at the statement of cash flow. So if you've got a machine, let's say your machine is a $2,000 a month lease, but you're going to bill out 12 CBCTs a month, well, then who cares about a balance sheet number? Your statement of cash flow, you're generating more cash.
Sure.
And Donald Trump said it the best about foreign debt. He says, I'd buy your house for $1 billion if the terms were $1 a month for 1 billion months, because I can rent out your house for $1,000 a month. Yep. So he doesn't care about balance sheet numbers. He cares about statement of cash flow. It's all about cash flow. So Dale, you're saying if the X-ray head is generating a quality X-ray, and I'm picking it up on a quality sensor, and I got a quality monitor, the dentist that's telling a board-certified maxillofacial radiologist that the PA is a better image, are you saying, Dale, that he's wrong?
They're wrong.
They're wrong?
Yeah, the best film image you can get these days would basically still be in hand tanks. No one does that. You know what the quality of processing is like in a lot of dental offices after the chemicals weaken and they're not freshened up. If it's not fixed properly, you and I, over the years, Howard, because I'm a little bit more seasoned than you. That means I'm older. Happy birthday, by the way, today.
Thanks, but you got more hair than me, so I'll trade the age if I can get your hair.
You shave it. That's the problem. But anyway, when you think about it, we've had yellow and brown films in our cabinets, haven't we, over the years? Okay, you don't get that. And by the way, I actually took some older film-based X-rays, put them on a digital scanner, a transparency one that goes through the image, and captured everything. And then I discarded the color, did some image processing like we do with our tools and digital imaging, and I recovered the gray and yellow film-based crappy images quite nicely, thank you, and people were amazed. They said, "You're kidding me. Here's the original, and this is what the new one looks like on my video monitor." It's amazing.
And I also want to say about this technology as far as the patient, because I'm very patient-centered, is humans have a lot of heuristics. They have hundreds of decisions they got to make a day. Easy heuristics. Say you want a blender, and you go to Target, and Target is amazing on blenders because they have 10, and they're all at $10 price points. They start at $10, $20, $30, $40, $50, $60, $70, $80, $90, $100. And I'm sitting here thinking, well, I'd rather just buy the $100 one once and right. And then everybody told me, oh, you got the best one. So a heuristic, if a car costs $70,000 and another car costs $35,000, you assume the $75,000 car has twice as many bells and features and heuristics work. And one heuristics we're seeing with patients all over the world is that a high-tech office, they think it's higher quality dentistry. And when they go into an office and you got the yellow chart and stuffed with all these x-rays and you're going through all these pieces of paper, and then you go into another physician's office and he's got a stylet and a touch pad, like my physician, I mean, he's the best one I can find in Phoenix. It's so amazing. My blood test gets synced into his deal. And then he tells me, well, if you could get your blood pressure for this, and he hits a button, he says, according to this study, you'd live 2.2 years longer if you did this or that. And I just think the world of him. I just think he's so smart because he's so high tech, and he's telling me all these numbers, and then it's all emailed to me. And so you're going high tech. Okay, so the bigger decision, Dale, you said 50% of digital x-rays. What percent of the dentists have a CBCT or a 3D x-ray machine?
I knew you were going to get to cone beam eventually, but just kidding. Cone beam adoption has been actually more rapid than digital, believe it or not. Digital
Really?
solid state sensor. Now, I'll say more rapid because you don't have to own a cone beam machine to actually use the data from it. So more dentists are actually ordering, a scan or sending to a patient to have a scan, getting the data back to put in software to do implant planning or obstructive sleep apnea or whatever. I don't know the numbers. All I know is that the interest and the adoption is going more rapidly than it did for solid state detectors that go in your mouth. Many more applications. I mean, what do solid state intraoral detectors do? Cavities, bone levels, PAs, to look at the root apex. This cone beam digital imaging is really, it's on steroids. We see so much more information. Problem being, we see information in 3 anatomic planes of section. Sagittal going side to side, coronal going front to back, and then the traditional CAT scan, axial, going from head to toe, where they push you in a gantry. Don't do that with cone beam. It's one pass and you've got all the data to look at in 3D and or all those planes of section. So there's a learning curve, and that's one of the stumbling blocks. You asked me about adoption. The sort of, the brakes go on a little bit because docs do 2 things. Our colleagues say, when they buy it, they go, these are great, what am I looking at? So they want more information. Manufacturers can't provide that, so we have to put on programs. Number 2, basically when before they purchase, they go, I'm so afraid of missing something because there's so much more data there. I can't buy it at this point. So they talk themselves out of it. We got to get them past that hump. And when we do, when they see the applications, endodontics, implant, TMJ, paranasal sinus evaluation, obstructive sleep apnea, the list goes on, okay? They get better data to make better decisions. Where's the downside of that? Patients love it. They see better. Docs love it. There's less morbidity for the placement of the implant. So there is no downside. Everybody looks again at cost. Well, the cost, again, is recovered so rapidly, and the data's much better to make clinical decisions with. There's no downside.
I was reading an article on your website, and it made me think that we should say that the TMJ centers in America are on the Stevie Wonder, Ray Charles system because you showed it. Because a lot of these people, every TMJ patient's the same. They need a stent, they need a bite, they need an equilibrate. And then you showed a CBCT with clear as a bell, a particle. I don't know what it was. It was bone or cartilage or whatever in the joint space. You know the article I'm talking about on your website?
It's called a loose body up there. It happens in hips, happens elsewhere. Yeah.
Yeah. So how can you be treating TMJ if you don't even know if they have a loose particle floating in their joint socket? And by the way, what did that person need? I mean, did someone need to go in and retrieve that, or was that a surgery, or?
It depends, Howard. Again, what I do in my specialty is I keep my dental colleagues out of trouble. John Fluke, you've read some of his stuff. John calls.
We were classmates, and I was Farran, Farran. He was Fluke. So we sat by each other in every lab in class for 4 years. He's a great guy.
Yeah. Well, he calls me his get out of jail free card with cone beam because I look for the stuff that most dentists are not looking for. Now, having said that, if I report a loose body in the temporomandibular joint complex area, it might not be symptomatic enough for someone to go after, but it might be the reason they have the intermittent locking and the pain, and it can all go away with a simple surgery, not a big open flap thing on the joints. Nobody does that anymore, but just trephination procedure, tweak it out, steroid lavage, and bingo, patient doesn't have that problem anymore. So yes, the decisions to visualize pathology, to visualize anatomy in 3D color, when you need to, it's amazing. Let me just add one. What'd you learn in school on how to localize a supernumerary or some abnormality in the jaws? You learned buccal object rule or Clark's rule, or in some cases slob rule, same unlingual opposite unbuckle. That all goes away. You just do the cone beam, rotate, look at it, see it in 3D, make an instant clinical decision.
But in all fairness to our viewers, I'm gonna have to back you up and explain that, because the biggest complaint when I'm lecturing in Africa, Asia, and South America, they don't have the money for CAD, CAM, CBCT. So go back to those 3 rules for our viewers in parts of the world where they don't have the money for that type of thing. Go through those 3 rules. Slob. Go with slob.
Yeah, slob means same on lingual, opposite on buccal. So basically, if you saw, let's say, a supernumerary tooth, an extra bicuspid in the mandible, and you and I know that, we did tube shift or Clark's rule, we're all taught that. Or if we move our tube head, in one direction, and the object in there moves in the opposite direction, same on lingual, opposite on buccal. That's a very simple way of learning that, okay, or remembering that. If your tube goes posterior and the object went posterior, it's on the same side, same on lingual, opposite on buccal. So those are the things that they really go away. And when you say that around the world, and I get this because, I've lectured not as extensively as you have, but probably in at least 29 countries, and you don't have to own cone beam to use it. So there could be a specialty clinic, there could be a hospital. If they're educated to what we can do with cone beam, there could be a centralized, imaging area, and then the data goes back to the doc, and all they're doing is image processing, like they're doing with some of their digital technology. So. And
then, for the record, explain Clark's rule.
I wish I could. I don't remember Clark's rule.
Okay, slob's good enough.
Slob is the good one.
And I want to ask you another thing that dentists are always asking on Dental Town.
Sure.
There's rumors out there that come from the what was the old Sony camcorder?
Yeah.
That there was only one factory on planet Earth that made a camcorder, and everybody's name that you saw was one factory made it and then slapped all these names on there. And a lot of people are saying that in dentistry that a lot of these sensors are basically made by just a few original equipment manufacturers. Is that true? Is each brand you see, do they actually make all their sensors and that, or are these just the same piece of equipment? I'm talking about sensors and just
OEMing.
OEMing.
There are 4 or 5 real major chip manufacturers, that supply that. But in terms of how you put it together, many companies make their own. I won't say they all do, because some of them rebrand. They buy it here and then rebrand it and put it in with their package. So I couldn't tell you how many there are, but let's say there's 20 solid state detector products out there. I would say that probably closer to half are made by that company, by its own company. But that early on, their comment was probably more true, that there were only 3 or 4, major people that put it together based on the specs that were requested from the company. We want rounded corners. No, we don't care. We want square corners. We want our connector on the back. No, we want it on the bottom. We want it on the corner. So I don't think you have to worry about that. To me, that's like a red herring from what you're hearing from our colleagues. Who cares who makes it? If it makes you a better dentist and makes the patient, decision making.
Well, be specific. Are there certain brands that you recommend that you think are better, or do you want to stay away from that for political reasons? Or
I always stay away from it because what I do tell people is, do you like the person in your office who distributes to you? Do you like your rep? Do you like the company that rep works for? If you do, it's often better to stay in the family because product support becomes less of an issue, But I also, on the other side of the coin, don't like, well, you have to buy our sensor because it's with our software and they won't work together. There's a lot of that gets put out there. Give you an example. At the Arizona School of Dentistry and Oral Health, when I was there as the Dean of Clinical Affairs, we put in an enterprise software because we had a big clinic, 100 plus users. We knew we were going to have remote clinics, so we wanted to be able to share that information remotely. So we had, before I got there, Sullivan Shine was the supply partner. We put in Dentrix Enterprise, and I'm just throwing these out because this is what we did. I'm not selling this on your show. When it came to the equipment side, what X-ray stuff are we going to put in? I actually said to Dr. Dillenberg, the dean, I said, we're going to put in Planmeca. He went, well, that's not Shine. I said, I know it's not, but I've had it in 4 schools. The stuff works. I'd like that. I'm the radiologist as well, so this is what I want. How are we going to make it work? Twain drivers. So the first image we took, by the way, the first day we opened our clinic, guess how many emergency patients in addition to the ones appointed we had? We had 50 people standing at the door day one, okay, with emergencies. And one of the local oral surgeons who was on our staff comes running down. He says, where'd you get that Panorex? And I said, the one over there on the screen. And he's looking at the digital. That is so much better than my film. I said, I know, Saba, but I said, aren't you impressed that she's still putting on her earrings and you already saw it upstairs? And he was, oh my God, I never thought of that. So, I mean, yeah, I'm a little bit off topic with that, but we put in a different type of equipment. It didn't matter because with the way they can communicate together, it captured, came up in Dentrix on our screen immediately. So not a problem.
And by the way, I want to say that when I was lecturing in Helsinki, Finland, I went to the Planmeca headquarters, and oh my God, what a class act!
Pretty awesome.
I mean, there's just Scandinavia's got some amazing companies, just amazing. So I'm going to we're at halftime, 30 minutes down, 30 to go. So Dale, you said about a half had digital radiography. What are you thinking with CBC right now? You think it hit 1%? Do you think it hit 5%? Do you have any idea of how far to go?
No, I really don't. The manufacturer, and people ask me that question, but the manufacturers don't share their data at all. And so I can tell you when you sort out the players, okay, the actual companies, I can tell you that.
Let's go through the players.
I knew you'd want to know that.
I want to go through the players, and I also want to tell you that a big dilemma everybody's having. It's easy if you're an endodontist and you just want a small field. You just work on one tooth. Mm-hmm. You know if you're an orthodontist and you just want this large deal. General dentist is kind of stuck between a rock and a hard place because he does endo and he might do ortho. So let's go through the major players. And then also tell them the pros and cons of. Do you want to talk about? Well, first, why don't you explain about the different needs of an endodontist working on a molar, looking for missing anatomy, versus an orthodontist who's looking at all the teeth.
Sure, and you know what's happened in the industry, which is a good thing, is that from user feedback of the bleeding edge, the first users, basically it became very apparent to most manufacturers that they couldn't just have a small field of view or a large, okay, or something in between, that they had to be able to collimate or change that field of view. So you're seeing a lot of product come out now that has a lot more capability. I mean, you can push a GUI, the graphic interface, user interface on the keypad, and select an area that you want. So, an endodontist has different needs, obviously. They have only small volume needs, 3 products out there. Carestream has one, J. Marita has one, Planmeca has one, and I may be missing somebody, but those 3 all make smaller field of view capture units. That
was Carestream, J. Marita, and Planmeca?
Yeah.
They all make go ahead.
They all make a machine that with actually quite a small field of view, and even a couple of those you can't make them any bigger. Okay,
let me just interrupt you one thing on this small field of view. When you talk to elite research endodontists, they will tell you that the number one cause of a root canal failure is too much preparation. You flare out the canal, you substantially weaken the tooth. But number 2, they will all tell you, is missed canals.
MB2s.
MB2s on maxillary molars, buccal canals on the distal of first and second molars, and lingual canals on mandibular incisors. And they will tell you that they're just routinely missed. And to be able to see your molar before you walk in there and say, oh, that's clearly got this many canals. And just knowing that when you walk in there. So this is very important for endodontics.
Yeah, it's huge, and actually, myself and Marty Levin, okay, who is an endodontist, I'm the radiologist. What we've done is the AAOMR, my group, the radiology group, has approached all the other specialties, and we're putting out joint position papers on the use of, cone beam CT or cone beam volumetric imaging, probably a better term.
What did you like more than CBCT? What did you like?
Well, it's a moot point. In my first textbook that sold out, it wasn't called cone beam CT. It was called cone beam volumetric imaging. And the reason I did that is because it isn't CT, okay? And again, bears no resemblance in terms of the way you capture. Just the end product looks kind of similar. So, but I was knocked down by a number of colleagues and others that said, unfortunately, where cone beam CT got into the literature early, if you search, you do a search engine or you go to PubMed or whatever, and you type in cone beam volumetric imaging, you're going to get 9 papers. But if you type in CBCT, you're going to get 2,009 papers. So I had to acquiesce in the second edition, and I'll send you a still image that you can put into the polished, finished product of this podcast, and you'll be able to see the book. But and I forgot what we were talking about now. The cone beam. Endodontics.
Endodontics.
We were the first group done. Marty and I were the co-chairs, Marty Levin and myself, and we had wonderful people on our committees that did really, really hard work. And we published in AAE and on our site, the website for the AMR, we published the guidelines for the use of cone beam and endodontic. And then came along, they're doing TMJ, there was one for implant, they're doing it for third molar extraction. There's going to be position papers on all of those that eventually work their way into our offices and our literature. Okay, so endodontics, it's a given. I mean, I truly believe, and by the way, endodontists now, Howard, endodontists have failures. And you know why? Because we send them all our crappy cases, okay? So what are they going to do? They're going to retreat, or are they going to, take that offending tooth out and maybe do an implant? So endodontists are really seriously interested in actually doing the surgical piece for the implant. Still goes back to the general dentist to restore, as always, okay? And they work through scopes. They're surgically oriented. So I don't see that as a bad thing. I see that as a good thing.
And endodontists also say that a lot of dentists who do their own endo will see a failure and will spend an hour and a half appointment doing a retreat. Whereas if you had a CBCT, you'd find out either A, it was a missed canal, or B, you also see root fractures on these.
Yep. And then now you go to an implant rather than try and beat your head against the wall retreating the tooth.
And also it's patient-centered because endodontists will tell me this, and tell me if you believe or you agree with what they're saying, is that a standard x-ray, a two-dimensional x-ray, a PA, is not going to see a periopical radiolucency till it's at least twice as large as what you would see on a CBCT. So if you had a CBCT, you'd say, oh, Dell, there's a periopical radiolucency number 3. Then you test it and it's not vital. And you say, okay, let's do endo now. And it's totally asymptomatic. Whereas a 2D picture, you wouldn't pick that up. And then Dell comes back, calls you 8 months later, and it's exploded, and he's in pain. And now you have a more difficult treatment. Because like in one step, an asymptomatic tooth, but you might not want a one step, a symptomatic.
Right.
So is that true? Can I see a periopical radiolucency smaller earlier than on a 2D?
Absolutely. And here's the deal. You and your endodontic colleagues and our colleagues that still do their own endodontic procedures, they basically are using it to assess it at the front end. As a radiologist, I'm looking at a volume of data, large or small. The amount of residual apical periodontitis, or the lucencies that I see, is just astounding. Okay, so I'm the validation at the back end. I wondered why that tooth was acting up. Well, here it is. There's a lucency in 3 anatomic planes of section. And remember, our
you're talking about after treatment, significantly after treatment?
Oh, yeah. I see so much residual periapical radiolucency that the endodontic community that I know, both here in North America and over, worldwide, basically, are saying our success rates are going to go down now. And I said, why? They said, because we have tools where we can see one of their criteria was no residual radiolucent area. Well, guess what? There's a whole bunch of them.
And you're also seeing a retreat from the one step, aren't you? Where
Yep.
everybody was just one step at a root canal and saying, oh, you can do it all in one appointment. And now you're finding like, well, maybe not. Maybe you should put some inner canal medication in there and get
Yep.
rid of all that infection first.
And the other thing I'm seeing is that, when you look at the number of steps involved to retreat versus, okay, I give up, this tooth beat me, we're going to take it out and put an implant in. I'm seeing a transition to that tremendously because predictable, implants are much more predictable. And think about an endodontic office. What's a typical unit of time? It's about 10 minutes. Who wants to be having someone file their canal for an hour and a half? You don't want that. So endodontists do it quickly. They do it efficiently. If they have to retreat something and take 6 units of time, over a retreatment when they could have just extracted, put an immediate implant in and sent it back to the doc so that when it healed, they could restore it. That's a much better scenario for the patient.
And I want to say something else. There's the fastest growing segment of the population, you and I know, live in Arizona, is senior citizens. And the fastest.
Who you calling a senior citizen, buddy?
All the people in our backyard between your house and mine. Fastest growing segment of the U.S. population in percent wise is 100 to 110. The second fastest is 90 to 100. Third fastest is 80 to 90. And women are living 5 years longer than men. And one thing that I don't see anybody talking about, which is the 4,000-pound elephant in the room, is that I've been out here 27 years. There's a dozen nursing homes within, in my zip code, and I have to go there and see them. And that lady that got the 4 implants and 4 on the floor, she's sitting there at the table playing bridge and eating anything she wants. And when they start getting rheumatism or dementia or Alzheimer's, they're just wiped out by root surface decay in literally, I would say I'd say between 12 to 18 months. Her 75 years of dentistry is just in the trash can. And we just don't talk enough about biology. I mean, when you got a titanium implant that cannot be eaten by Streptococcus mutans, and a lot of people are saying they get perio around there, but not the periodontal disease you see around a tooth. I mean, you might get some inflammation, some crestal budding, but you don't have the full-fledged periodontal. And if you don't believe me, what happens to a full mouth of perio when you extract all the teeth? It's all gone, right?
God.
And so when I go to those nursing homes, Dale, there's no one in there that looks like me and you. It's all women. And, I think the average white male in America is 74 years of age, life expectancy, and the average female is almost at 80. And you go in these nursing homes, there's 100 women and one man named Lucky. And I don't even know if I want to do molar endo on a 65. For me, at 65 years old, I'm sitting there thinking, and I talked to an insurance actuary. He said the best rule of thumb to predict a patient's age, if you don't want to be an actuary and ask 1,000 other questions, is a male and a female in America is most likely going to live like a year and 2 months longer than their dad or mom. I mean, just the being average. So when you're looking at a 65-year-old lady and she needs a root canal, and you say, how old was your mother when she passed away? And in Phoenix, half the time they say, my mother, she's still alive. And I'm like, oh my God. Oh my God. Should I really be putting a tooth in here? So you talked about, and I want to say one more thing, the low-hanging fruit on the on what you just said, is dentists always schedule a 6-month recall for a cleaning. But when you do 4 out of 5, the average dental office has 5,000 charts and 1,000 are active and 4,000 have just fallen off the charts or what have you. But you know what? When you do a root canal, you schedule a 1-year follow-up deal. And you say, hey, you just spent $1,000 on this root canal and I want to see it a year later to make sure it all healed up and we don't have to do anything. And then what that does is the only definition of an active patient is someone scheduled for employment. Now I know Dale just walked out the door, but at least I got him scheduled to come back sometime, even if it's just for a PA or a CBCT of that root canal. So that's good. So we talked about small vision, and then orthodontists want large vision. Let's go through the companies, Dale. We're 45 minutes into this. In the last 15 minutes, go through these name brands because dentists want action plans, and they don't want to. I'd like them to listen to this and say, and they decide I'm going to get a CBC give names, give companies names,
Sure.
and let's walk through this.
Yeah, I'll do it like I lecture, okay? Because, you know, I am a general dentist. I did it for up till 99, private practice 7 years, a bunch of years in school, 1 day a week. When radiology became a specialty, of course, I narrowed it to my specialty. But I think like you, okay? I was one of you, right up till 99. So general dentists don't necessarily want a small field of view because that limits them. Some of them don't want a large field of view because they're worried about the information in the scan. So what's in between? I always tell them, look, you've got machines that will do a dental alveolar volume, 8 by 8, okay, 8 by 8 centimeters, and that for most purposes will suffice. But you also have to think about multifunctional machine. What do I mean by that? I mean, you're not going to do a cone beam on everybody just because you own the machine, no matter how quickly that helps you recover your ROI, because you have to sit down, examine the patient, determine the need. It's just another tool, okay, cone beam. What if you have a machine that does a panoramic, digital panoramic, extraoral bite wings, okay, or bite wing appearing? By the way, they're not just bite wings. When you look at them, you see the periapices from the canine back. It's like, oh my God, I've narrowed this down to about 6 images I have to put in the mouth. So the deal is you want to look at companies that make these, quote, multifunctional machines. I hope I don't miss anybody. I didn't prepare and make a list or whatever, but you've got CareStream, you've got Instrumentarium, you've got Plan Mecca, you've got Gendex, okay, you've got Vatek, you've got SUNY used to they don't relabel the Vatek machine anymore, so that's gone. I'm probably missing somebody. Oh, Instrumentarium now. The imaging sciences have a Flex or one of those machines that actually allows you to do smaller field of view. Now you have to do your due diligence. You have to look at the machines and say which ones do all of the things that I said, and which ones do them well. But if I were a doc, I'd think of one that does more than just cone beam. It does cone beam when you need it, but really does the bread and butter sort of imaging of a digital pan, a high quality digital pan, which you can make a lot of decisions on. And let's give you, for instance, we're going to maybe do another, podcast down the road on dose and how to talk to your patients about dose, intraoral right up to cone beam. But let's say you got a 9-year-old and the manufacturer said, well, doc, you can do all your imaging with cone beam. You can get a panoramic out of the cone beam. Well, yeah, you can. But as low as the dose is, it's still higher than a digital pan. So if you get a 9-year-old and all you're assessing is are the successor teeth there in the right locations, you cannot justify doing a cone beam on that child, okay, just to get the pan, when a pan would be 5 to 10 microsieverts, versus 100 microsieverts. Not justifiable. So just because you own a machine, a cone beam machine, doesn't mean everybody gets one.
And let me
get one. Wait a minute. Get one that actually is multifunctional. Then it also helps pay for the cone beam portion.
And Dale, when you go from a 5 to 10 to 125 units of radiation, are you still mostly concerned about the thyroid, and does the thyroid color play into this, or is there other things that you're worried about?
That's a whole other podcast, Howard. But yes, on children, the NCRP guidelines adopted by the ADA and FDA say that every child gets a thyroid collar unless it interferes with the examination. Well, guess what? On a panoramic or a cone beam, it comes off because it does interfere with the examination. It will put artifact in areas you're trying to interpret. So there are a lot of changes to guidelines which dentists, they've been published for a lot of years, but dentists have they're guidelines. They're not rules. They're not mandated. So we can talk about that in other podcasts because I got lots of information to help people about that. But cone beam for the most part is, let's say you were an implant doc. That's what your main part of your practice was. The ones that have been doing it for a long time would say, well, I use CAT scans because it's more accurate information. There's no justification now that cone beam's here for doing a CAT scan in a hospital unless you live in podunk somewhere and the only access you have to any 3D imaging is in a hospital with a scanner. Cone beam, being such a low dose procedure, should be, they got to get be careful about standard of care, but it should be the only modality that somebody uses to assess an implant site and do their planning. Okay? Dose, all about the dose.
So
I know.
again, go ahead. Keep going.
I laid out the manufacturers sort of by name. I think what they have to do is look at those that will do multifunction, and it'll fit better in their practice. Okay.
So then I'll ask you another question.
Yeah.
Market share. A lot of dentists don't care who wins the People's Choice Award on a song or whatever, because that's all artsy fartsy. But market share becomes very important in dentistry, because everybody voting with their dollars or voting on the Townie Choice Awards, everybody voting has got 8 to 12 years of college. Dentists are notorious for paralysis from overanalysis. They make decisions very slow. And when they do make a decision, they make a lot of good decisions. I mean, these are smart boys and girls that know math, physics, chemistry, biology. Who are they mainly buying?
That's an interesting point. I think the largest number of units is worldwide is probably Imaging Science ICAT. They were
ICAT.
They were to the party early. They had a machine that was less expensive than some of the earlier versions out there. It was one of the first sit-down machines. Okay, there are some limitations with some of it, though. It has an aluminum arm that comes around you, and some larger patients can't get in there. Okay, on that aluminum arm is a bite pin. Well, if you're on a bite pin, there still could be some movement. Well, movement kills a scan. So, even though it's a high seller, I haven't seen enough improvement for stabilization of the head and things that will affect the scan. Having said that, I see good quality scans from people that pay attention to gathering them. PlanMeca's big, CareStream's big. Vatec make some inroads, but I'm not as convinced that they support the product the way that the others do. Okay.
Where's Vatec out of?
They're out of Korea.
Okay,
they have offices here in the U.S. as well, and they have a lot of.
But you're seeing customer service issues with them?
I'm not seeing them. I'm hearing about them. From everybody. Every company has issues, but I heard more from that particular product. Gendex is basically a version of iCat. I don't know if you knew that or not. So is the Cavo machine, which isn't sold here. It's sold in Europe.
Is that because they're all owned by that big holding company? What's the name of it? Danaher. So
yes.
Danaher owns all these players, since they're all owned by one guy, are they integrating them in different ways, or? Hard to say.
Good question. I don't know. By the way, one of the companies that I missed was J. Morita on those multifunctional machines, and you should put that one on your list, because it's been my experience, and things change. As look at Samsung and the success of Samsung out of Korea. That's a huge company that makes lots of inroads on the consumer side and makes great products. But I always used to say, and I still am of the belief, that companies in Finland or Japan make the best X-ray equipment in the world. Okay.
Finland and Japan. Finland being Helsinki, Finland, PlanMeca,
and Instrumentarium as well.
And Instrumentarium.
Yep. Now that doesn't mean I'm dissing the rest. What that says is that they were early to the party with panoramic, so they have been able to grow and develop, their products much longer than some of the other players out there. So.
Yeah. So, by the way, when you lecture in Korea, when you lecture in Asia, I think it's so funny in China. If you're dressing really fancy, a compliment in China is that, oh, you're looking Korean. Because they, what are the three big brands? Samsung, Hyundai, and what's the other one with the happy face? I always forget that one.
LG.
LG, which Americans say stands for life is good, but it's not really. Not exactly the correct Korean translation, but this is interesting technology. So, Del, I got you for 5 more minutes.
Okay.
What I want you to do for the last 5 minutes is a big close to a dentist is sitting there, and I'm gonna set this question up like, don't look at the balance sheet number. If you took 10 of these a month, you're gonna pay your monthly payment. So let's take money out of the equation, because it might make your balance sheet number look ugly, but I guarantee you, everybody I know increases their statement of cash flow and their cash flow. So let's take money off the table. You got 5 minutes to close this thing up. Why should I really buy a CBCT? Isn't this kind of a big decision?
It's a huge decision, but it's going to make you a better doc. It crosses a lot of the disciplines, the things that we do in dentistry, so that you're not restricted, to, hey, I only do cosmetic or whatever. It goes across the board for a lot of things that dentists want to do. Makes you a better diagnostician. If you have the data in order, those points to make decisions about the treatment that's most appropriate for your patient, there isn't a better imaging modality. I do want to caution people, though. I know you said money's off the table. Remember, you still have to examine the patient for every radiographic procedure and determine the need. So although you say 10 a month and it'll pay for it, the goal is not to do 10 or do 15 to increase your bottom line. The goal is really to treat your patient better, which is what you're all about. So I don't think there's a better modality. I think they'll continue to make improvements. You may see pricing come down a little bit, but I don't think pricing should be as huge a decision point for you once you look at the applications and all the things you can do for it. One thing I will do, though, I'll caution everybody, you can't learn this vicariously. You can't learn it in a short period of time. There is a learning curve with it, not just what the manufacturer teaches you, but you have to revisit anatomy. You're going to be looking at areas you're not used to. The amount of what we call occult pathology you weren't anticipating that I see. I've read over 17,000 scans now off all the different machines, and I find something in every other scan to report, and probably every fifth scan to refer. So
now for me personally, I upload ours into a Dropbox. Actually, I'll be honest, my assistant Jan does it, but tell them how if they want you. You read 17,000 scans. You're the top in your field. I take the film, and then there's a button, and it goes to a Dropbox. Tell them how I send it to you, and there's listeners around the world. How can they send you a scan to read a scan in detail?
Right. I don't use Dropbox. I have had patients, clients rather, send me Dropbox or Hightail or one of those products, okay? And they're encrypted and for the most part pretty darn secure, okay? But I have a server in my home. I assign a user ID and password that only you can get in and only you can see your file folder. The DICOM data is exported from your machine. The image data is in what we call a DICOM format, digital imaging communication in medicine format. It has to be in that format because not only the image information, but a lot of the things about what body part, what was the KV, what is this the first time they were imaged, travels with that. Once it goes up into my server, I get them to send me an email that says patient name and date of birth. That's it. That's all I want to know. I don't want to know anything else unless there's something real specific. Because I don't want a lot of data going around the internet that could be in violation of HIPAA if someone got a hold of it. So then I put it in a third-party software. I can't afford everybody's software from all the different machines. So I read in a third-party, very robust software called Cyberman On-Demand 3D. On-Demand 3D, great software. And once I capture images like screenshots of the interesting things, I put it in a report. The report is, and I can talk to you about that at some other podcast, but the report is then put in a PDF file back in their folder that only they can access. They drag it down, basically then put it in their patient's chart or print it or refer when necessary.
And what I love about my podcast is the dentists are usually multitasking. They're listening to a podcast.
Sure.
They're mowing the yard. They're riding their bike. They're vacuuming, doing laundry. Will you email me? Whatever you email me will be following the transcription, because I don't want some dentist right now parking his bicycle to try to get the notes for what you're saying. But I wish you would email the exact instructions of how my listeners can send you a CBCT and start this process.
Sure. And I want to do one last thing, Howard. I don't know if you can see this or not, but I want to hold this up.
Happy birthday from the two most interesting men in the world. Oh, that is awesome.
To the third.
Oh. Well, Dale, to those of you who don't know Dale, I live in Phoenix because I'm poor, and you live in Scottsdale because you're rich. But
Fountain Hills.
Oh,
Fountain
you're not
Hills.
in Scottsdale. You're in Fountain
No,
Hills.
no.
And by the way, Dale, I have to ask this, but sometimes you sound like you have a Canadian accent. So explain that to the viewers.
Well, I'm a Camerican. I'm a Canadian-born, American naturalized, Frankfort, Kentucky in 1999. I can talk like this and do the interview if you want me to. But I have spent 32 and a half years in each country, and I love them both. So that's why I heard the out and house and about.
So just to be clear, you have multiple accents, and you can lecture in any format. So when you're in Kentucky, you can turn on the Kentucky.
Absolutely. We'll go do the Greater New York together, you and me, okay?
But you're a legend in the field, Dale. Thank you so much. And you have a course on Dental Town too, an online CE course on Dental Town.
Yeah, we're working towards putting more courses out there for you as well. So yes, and I appreciate the opportunity to do this is my first podcast with you. So
wow. And Dale, seriously, thank you not only for everything you do for dentistry, but everything you've done for Dental Town. You're a great neighbor, a great friend, and the students. When I lecture in the dental school, I think you're the favorite lecturer over there. I mean, I'm seriously. I mean, like Eric Harris. Those guys love you. They worship you. You're a great guy. Thanks so much for giving me an hour on my birthday.
There you go. Happy birthday.
All right, buddy. Bye-bye.
Thanks, Howard. Bye.